And you're watching Q&A with Dr. Makela, where we talk about topics of geriatric medicine, hospice medicine, and of course, cannabis medicine. The Today, we're going to be talking about a few different things. Welcome, everyone. As usual, I'm here for your questions. This is a live stream, which means a chat, and everything you guys say is just as important. And so I love hearing what you have to say. Don't hesitate to throw in comments or throw in questions that you may have as we talk. As usual, I start off with a little bit of something to talk about. And so for today, I want to talk about, um, I wanted to talk a little bit online. We've actually been having some conversations about a heart disease. Now, heart disease is the number one killer in America. A lot of that's because people now live long enough to have heart disease. So that is, you live old enough, eventually you're going to die of your heart, most likely, or cancer, which is number two. The But there's also a lot of early heart disease, a lot of people who die very early. We see this in a lot of communities that don't have access to good health care. Um, a lot of African American communities um, die very young, about sometimes 20 years earlier from heart related disease or vascular disease or strokes. To be honest, strokes and heart attacks are really kind of the same disease if you think about it in this. Your blood vessels, run throughout your whole body. And so as you build up cholesterol and as you build up fat and stuff and on the cholesterol on your blood vessels, as the LDL fats build up and they start kind of closing them off, that's not just happening to your heart. It's actually happening globally. It happens to your brain, it happens to your kidneys, it happens to, all your feet. And so that's why, like with diabetics, we talk about foot care is so important because diabetes makes you prone to this. It makes your glucose higher, and that glucose is kind of like having caramel in your blood. Is probably a nice way to think about it. My endocrinologist, please don't come after me and say, no, it isn't. It's a nice analogy. It's not technically caramel in your blood, of course, but it's this idea that having high sugar uh, tends to make those blood vessel walls more sticky, and so they're more likely to get clogged. Also, high blood pressure can kind of cause shearing effects on those blood vessels, and that can get them clogged up. Now, because that irritated, sheared wall is going to be more prone to getting clots on it, then followed up by then having higher cholesterol in your body. And so all of those things, and it's not just cholesterol, it's like the LDL fats and all the different unhealthy fats, right? Those all build up and you can get plaque on your walls. It kind of like the gook that builds up in your sink pipes, right? And now your sink pipe is going slow. And if you kind of router it out, there's a lot of gook that comes out, and you're like, ugh, where did that come from, right? That's kind of the same thing that's happening in the blood vessels. Now, what can happen is that plaque can actually rupture and break open, and it can actually what they call rupture, where there's like a kind of a liquid on the inside, kind of like a little volcano almost, or think pimple, right? You know, it can rupture open. And when it does that, it creates more clotting factors and it can actually completely obstruct the heart. And that's how they think a lot of heart attacks happen is that you have this plaque and it's at a critical level. It's like very narrow already. But now, if it breaks open and kind of the equivalent of like the pus from a zit, right? So think of like how a zit ruptures and then a bunch of pus comes out. This isn't pus, but the cholesterol liquidy stuff underneath the wall of that kind of comes out and closes it off. And that's a heart attack because suddenly now it's closed off and you don't have blood going to your body, right? And you're like, or to your heart, and that's a heart attack. Well, if the same thing happens to your brain, that's a stroke. And you don't need to have a heart attack or a stroke to have damage from that because you can actually have small vessel disease. So the tiny, tiny, itty bitty little arterioles um, that go to your capillaries and stuff, right? If those get clogged off, you might lose a few cells and you're never going to notice it if it only happens once. But usually, when people have this, it happens to several of these small little arteries. And over time, you can get what's called ischemic cardiomyopathy, fancy term for damage to the heart that's not necessarily caused by a heart attack, but might be an accumulation of a bunch of smaller blood vessels clogging off and killing only a few cells at a time, building up over the course of months to years. The same thing can happen when what we call vascular dementia, where you don't have a stroke, but a few cells die here and there in your brain over time, and you start getting some brain damage that looks like Alzheimer's. Now, as a specialist, I can sometimes tell the difference between Alzheimer's and vascular, and you can actually see it in imaging when people have vascular dementia. But that's why I say vascular disease, stroke, and heart attack are actually very similar. Now, what's interesting is that there's a lot of things that are protective. And for the longest time, we talk about things like flaxseed. Like I always tell people, add some flaxseed to your baked goods. You're making some pancakes in the morning, add a handful of flaxseed. That's extremely good for you. Or we talk about the Mediterranean diet. There's really good data that the Mediterranean diet or the DASH diet or the Scandinavian diet are all very good for you. And the things they all have in common are they are very heavy in fish, like fish twice a week. They also are very heavy in whole grains. They're heavy in healthy oils. They are healthy in they're not as well, they're not as meat based, but you can have a little meat. You can have some. It's not restrictive. It's not vegan, but it is, and it's not very high sugar. Again, you can have a few, little carbs, a little this, right? But the Mediterranean diet, it's has been shown to improve health. And again, what's interesting is the omega 3. So, when we talk about fatty acids, there's your trans fats, which are really bad for you, your saturated fats also, and then your unsaturated fats, you have your omega 3, omega 6, and omega 9, right? And the poly and the mono unsaturated fats. And so omega 3, omega 6, and omega 9. And omega 3, the number one source for omega 3 is fish oils. Though you can, in some um, eggs where they fish, my tongue tied, where the chickens have been fed grain that's heavy in omega 3s, you can get omega 3 eggs. There's also some grass fed type beef that may be a little bit more omega 3 ish. Uh, but flaxseed, hemp seed are two probably, you know, common things. So your chia seed. So those are things. So whenever I talk about adding a little bit of flaxseed or hemp seed powder is also a great choice to baked goods or to a smoothie or something like that to increase your omega 3. Though the flaxseed and that doesn't convert as readily as the seafood based versions. So again, this is where adding some fish to your diet can be extremely healthy. Now, what I have learned over time is that the fish is that omega 3, that what that does is that actually works on your endocannabinoid system. And so I've talked before how we have a natural endocannabinoid system in our body that regulates all sorts of things. One of the things it does do is it looks at that vascular endothelium. Again, that lining, right, where all that plaque is, and it kind of helps it out. It can counteract some of that LDL accumulation, all that fatty accumulation. And so you have some omega 3, and it's going to decrease your chances of having vascular problems and vascular disease. Now, what we're finding, and again, you have endocannabinoid receptors on your blood vessels. So it seems like it might be tied to that. The other thing is that omega 6 becomes actually the endocannabinoids, the AEA, the anandamide, and the 2-AE, our body's natural endocannabinoids. Omega 6 becomes that. Now, omega 6 is essential. And what we noticed is that you need it. There does seem to be a little bit of a play between the two of them that omega 6 tends to raise the endocannabinoid tone and omega 3 lowers it, and the two kind of balance each other out. Now, for the longest time, they were saying they have to be in a perfect balance, and I've even repeated that because I've seen several studies, but more recent studies now are kind of showing that it's maybe more just a factor that people aren't getting enough omega 3. And omega 6 we do perhaps get a little too much. And there's still a little bit of gray that, in our American diet, where most of us are overweight, if we're taking the processed food with a lot of omega 6, that maybe you might be experiencing that in a more negative way than someone who's healthy and athletic and taking it. The other thing is to realize that you shouldn't jump on that and say, "Oh my gosh, omega 6s, they're bad. They're over revving your cannabis system. We need to get rid of them all." There's a whole group of people who are like, "Ooh, seed oil's bad," because that's where a lot of omega 6s come from, is like your seed oils. That's a little bit of an overkill. First of all, a lot of things of those seed oils are on a scale. Some have more, some have less. Canola has less. And yes, there are questions about like if you deep fry with it, put them in high heat, and you reuse it over and over, you're getting some trans fats you're created. That's a whole issue, right? But then you get people who are like, "Ooh, seed oils are bad, so we should take beef tallow." Like, no, don't do that. No, no. Beef tallow, I mean, it's nothing is inherently terrible for you, but beef tallow, not the best, not it has these it's not, no, it's not healthy. The data after data after data shows if you have a diet rich in beef, but again, moderation. Is a handful of French fries made in beef tallow going to kill you? No, of course not. You know, if you have it every day as a main core of your diet, yeah, maybe. You know, the data seems to suggest it's not good for you. But that's all just to say that there's this whole deep end of that seed oil, and I want to caution and just say omega 6s and maybe deep frying in canola oil is still no better, right? Maybe we just say French fries should be a sometimes rare food, a little treat, not a regular way of living. Now, then, maybe some of the heavily processed stuff where in the factories they are putting like, adding sugar, adding oil, adding this and ultra processing it. That's maybe not good either. It's increasingly seen. And then there's omega 9s, and those are your olive oils and some degree your avocado oils and stuff like that. And those seem to be very healthy for you too. They also seem to modulate the ECS. So I find it very interesting that the Mediterranean diet, once you understand the ECS, you actually understand that a little bit better. Now, how does that talk about cannabis? Well, there's been a lot of questions about, is cannabis safe for the heart and does it cause heart disease? And the American Heart Association came out and was like, "Ew, we don't suggest, especially smoking it. We don't suggest that." And there's been some new studies that have come out in the news and stuff like that where they have talked about, oh my gosh, cannabis doubles your risk of heart disease. But when you look at it, it doubles from eat to eat. It's just, it's not like doubles, it's doubles from point something to point something, it's not a, and then a few of the studies really did have sort of methodologic problems where I would say they don't say as much as the news would say. And then there's still an ongoing study called the Cardia study, and the last I have seen of it, it's looking at people, I think it's been going on for about 30 years right now, where it looks at people who have cannabis use. Not just cannabis use, but it started looking at a group of people when they were younger and has followed them over the course of their life and say, what is things in a lifestyle that are causing risk for heart disease. And one thing they did look was at cannabis, and they're not seeing any further worsening indications of heart disease 30 years into the study compared to anyone else. So I would say the jury is out still as to whether it's specifically bad for your heart. Now, I was talking about the omega 3s. And remember, the omega 3s, they kind of counter that increased endocannabinoid tone, and they're extremely good for your heart and your body. And so the question was, should people with cannabis use take more omega 3s? And actually, I asked a handful of people. I asked some endocannabinoid specialists, I asked some cardiologists, did some searches, and there doesn't seem to be any studies to suggest that if you have if you use cannabis that you should take more omega 3s or a supplement. In fact, there's data to show that the supplements don't actually protect against the heart. You really do have to take the fish. You really do have to change your diet and eat more omega 3 to really have an effect. And maybe that's because if you're eating more fish, you're eating less unhealthy foods, right? Or maybe I joke, as those in the cannabis world know the term the entourage effect, which is the idea that the whole plant, like a whole plant extract or the whole leaf, has a more powerful effect than just the THC extracted alone. And they call that the entourage effect, where everything else along with THC makes it better, stronger, whatever. And so I call it the fish entourage effect, meaning you can't just take the omega 3 fish oil, you have to actually take the whole fish. Bad news if you don't like fish or if you're vegan or stuff. I mean, I believe there are some vegetable sources, maybe in seaweed or something, of omega 3 you can take. Um, but yeah, so that is, and so yeah, so if you smoke cannabis or use cannabis, there isn't any specific data from anywhere that says that omega 3 would be more protective or you would even need more protection. Because first, you may or may not be at increased risk of heart disease than anyone else. Two, there's a lot of other things that are increasing your risk of heart disease, like our American diet and other things. And three, everyone should be taking at least, should be increasing their amount of omega 3 they take in their diet every day. And so that was kind of the interesting thing I learned about that, of going into this little deep dive of, yeah. So, moral of the story, Mediterranean diet, omega 3s, eat more fish, hemp seed, chia seed, and flax seed to your diet. And then, like the omega 3 supplemented chicken eggs and meat, if you take chicken eggs and meat, right? The Now, again, um, as we pause here for a second, the mm, I if anyone has any questions, if anyone's watching and like has thoughts, or if you're just watching, just chime in, say hi. Just as we talk and see what's going on. You know, the other thing I was talking to stuff was very interesting. You're allergic to seafood. I wonder if that's anything to do with my cannabis use. I don't think so. I think actually seafood. Here, I'll highlight that there just so people can see it there, read it if they can't read the small amount. Um, yeah, if that has anything to do with the cannabis use, I don't think so. There doesn't seem to be any cross reactivity between cannabis and seafood. And just because the omega 3 works on the endocannabinoid system doesn't seem to suggest that the cannabis, there doesn't seem to be any chemical similarity between those things, between seafood proteins and THC, where if you're using a lot of it, I it's an interesting thought, but no, there would be as far as how allergies work, there would not be. It's usually people just have at different allergies at different times to stuff. The yeah. So, but good question. Yeah, I can see where you'd think that, but no, it's not. The yeah. And so that is now on a different note, and again, feel free and folks to chime in with thoughts and whatnot. But I and by the way, there's about a usually LinkedIn, there's about a 1 minute lag to stuff. So feel free if you if I may stop what I'm doing to answer your question right away because sometimes there's a little bit of a lag on the LinkedIn that can create a delay there. Um, but yeah, now speaking of heart, I'm my other hat is I'm a transplant, not transplant. I'm a hospice doctor. So I deal with people at the end of life. And actually, what I deal with is a lot of people who can't get transplants, right? They don't medically qualify. And I was just recently talking, to a cardiologist and reading all this different things about transplants. Now, two things have come up. One, there's a whole question about whether or not if you smoke cannabis, if you can get eligible for a heart transplant. And that's a huge ethical thing because there's talks, there's always a limited amount of organs. And so we have to pick the people who are most likely not going to waste them. And so what we have is a lot of people, we don't want to waste them. And so what happens is we say there are certain people who can't get them. The most common thing, and probably the most universally accepted, is liver transplants to say, you have to be sober. We're not going to liver trans. If you burn through your liver from alcohol abuse, if you've been sober for 6 months, a year, depending on, then that's okay. But if you're still actively drinking, we're not going to give you a liver. And I actually saw that once in residency. I saw some lady who got a transplant, stayed sober enough to get her transplant and then relapsed and started drinking after the transplant and was now in rejection of her transplanted liver. And it was heartbreaking because not only did the person die who had to donate the liver, but chances are someone else died who never got that liver. And then she got that liver. Now she's dying because she continued to drink and is wasting. And so they want to avoid that type of thing and give people uh, organs that are going to be able to use them most effectively. And so there was a question of apparently in the transplant community, if you smoke cannabis, especially if you smoke cannabis, should you get a heart transplant? And especially with some of the questions that we've just had about can it increase your risk of heart disease? Is cannabis use, recreational cannabis use itself, a contraindication to heart transplants? And and this already has precedent in that many heart transplant programs will not take someone who's actively smoking because we know smoking tobacco increases your risk of heart disease so badly that they're like, no, 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 you're at so high risk of rejection and everything. We're not going to have you smoke, right? So you have to not be smoking anymore to get a heart transplant. So the debate about cannabis is going on. Now, there's a lot of really sort of gray issues. I mean, it's like, what are we saying when we say that? Who is this affecting? Is this a social equity issue even, right? Of who gets it and who doesn't. And so that's a whole thing. But then beyond that, let's say that's not, we take that out of it. There's actually two reasons that I would say that, let's say you don't get the transplant, but let's say if you have a bad heart or liver or any organ, kidney, right, you should really think twice about using cannabis. That this might be something you don't want to use. And there are two reasons. One, a lot of the transplant medicines actually play badly with cannabis. Now, tacrolimus is the most studied for this, and tacrolimus already is like a really, really strong transplant med. I mean, it suppresses your immune system. I years ago, God, 20 years ago, had a patient who was older who had it, and his levels went down a little bit, but older people have a suppressed immune system already. And so he probably didn't need to be lower, but they lowered it. And within a month, he got an infection and died. And I was like, oh, heartbreaking. It was one of my patients. And then, but if you don't have it high enough, you it goes, you can reject, and then you die because your organ is getting rejected by your body. So you need to suppress your immune system, but you too much, and you can get infectious diseases that can kill you. So tacrolimus has this very narrow window. Too high and too low is bad. Cannabis can make some drugs go too high or low in your system. Another bad one is warfarin, the blood thinner, where it's gone super high in some people. Tacrolimus, there was some case reports of it going 3 times of what it should be, which again is dangerous, makes you extremely prone to infection. Plus, at that point, you're getting to toxic levels. So and they say, well, you can, if you're using it for medical reasons, like, da da da, you can use it, but then the surgeons and the transplant team and the transplant doctors need to monitor it more often. Yes, but that is a really high risk drug. I would just like, unless you need it to live, if that's the only thing keeping you from having multiple seizures a day, that's one thing. But otherwise, really, really, do you wanna be risking your heart, kidney, or liver just to have cannabis? I'd say, no, don't do that to yourself, you know? Um, Second, and is again, we talked about immunosuppression, making you more prone even when it's working, you're more prone to infections, and the issue with that is when things are more prone to infections, you can actually, um oh, fungus. You can get fungal infections. And so, anyone who's been in the cannabis industry and is watching on LinkedIn, if you probably know that there's a lot of talk about testing for fungus, for different types of fungal bacteria, different types of fungus growing because it's a live plant. You dry it, and anytime you dry something, if it doesn't dry right, there's a chance that mold could build up on it. And aspergillosis is one of them, but there's a whole bunch of other ones, right? Of different molds that can grow on the cannabis plant. And then there's the chance that as you inhale it, as you burn it, that mold makes its way into your lung. And there's been some questions and some case reports and stuff of people who get really bad lung disease. So again, If you're immunosuppressed like that and severely so, you have to be very, very careful. Certainly, I wouldn't want you smoking it. I wouldn't want you using anything live leaf. I suppose once you start getting to the tinctures and things have been, heated and extracted through alcohol and everything like that, you're probably okay with that. But that is just something to be aware of, that cannabis can interact like that. So that's why if you have a transplant of any sort, not just even a heart transplant, but any transplant, I would strongly encourage people not to use cannabis unless they absolutely have to. And then it should be in discussion with your transplant team and your doctor so they know to be checking your levels more and monitoring you for different things. And like I said, avoid smoking it then and make sure yeah. So that's my take on it. Now, so, and then the last little thought about transplant stuff is on the news. This is my hospice hat, right? Is on the news, there's been a lot of stuff coming out. I know um, Kennedy and stuff has come out and talked about we need to fix this. And, you know, he's not wrong. I've been reading more and more as the news has been coming out of it. There's more and more studies about this. So, what's happening? Is our transplant system broken? Is it? No, it's they made a change. So, for the longest time, what happened is that you had to be brain dead. If you had no function in your brain, and I mean zip, if you as much as could move or little, involuntarily, you weren't brain dead. Brain dead was 0/0, you know, EEG, even though your heart and your lungs, and you were on a breathing machine because you're so brain dead that your your body doesn't know to breathe. But we have breathing machines now, and if the heart can automatically keep pumping, you can be alive where you have a pumping heart and you have a breathing machine breathing for you, but you have no brain function. And at that point, you're considered brain dead. And for the longest time, transplants were mostly for brain dead people. But that's actually a very narrow window. And so, with more and more people getting transplants and the technology being more readily available for people to get transplants, more people and people getting sicker, people living a little bit longer, more people needing kidney transplants, stuff like that, right? We have, they've expanded it. And I'm still trying to grasp all of this myself, just reading these articles in the last week. So if someone's hearing it and they say, "No, no, Dr. Makela, you're wrong," I could be. That's my first thing. But this is a live, what they call circulatory failure. And my understanding is it's no longer someone who's brain dead. It's someone who is being removed from life support, who does depend on the machine. They're maybe profoundly comatose. And now, when you remove them from life support, their heart stops. And their heart stops. When their heart stops, now they're dead, right? They're they've already signed do not resuscitate. Their heart stops. And so once the heart stops, they can do um, they can say, okay, they're dead, but they already have the transplant team hot and waiting, right? And the idea to get them there within like 30 minutes or something like that, so that you still have viable organs. There's a certain time period that they can scramble the transplant team to get there right after someone's heart has stopped. And that has expanded the amount of organs. So, quite a number of people who wouldn't have been able to um, donate can now donate. A lot of people who died, you know, whose heart just stopped for a variety of different reasons can now donate. And that's great. More people are living. The downside is that what's happening is that sometimes people aren't great at telling when this happens. And as someone who has seen a lot of people die at the end of life, I can tell you part of it's because it's not entirely an exact science. Sure, sometimes we know for sure that, yeah, if I take you off the vent, you're going to die within 5 minutes. Um, or I take you at least a couple hours and the team can wait until after, right? And so what's been kind of happening, it's I understand it, is that there have been people who haven't quite died. Who they say, oh, they're going to die. We take them off the vent. Do all this. We do that. They're going to die. And everyone gets a little too hasty. And they're like, oh, we don't want those organs to go bad. We don't want those organs. We know the person's going to die. And there's been a handful of cases. There's been some cases where the person wasn't dead yet, but they still ended up dying because they were dying, you know. Um, and then there was a couple newsworthy cases, and all you need is like two, right? And I think there was like one in Kentucky and one in, I want to say, Arizona, that both made the news where the person wasn't dead yet and they were on the verge of taking the organs out, and the doctor, thank God, both these cases, the surgeon, did a final little check and said, "Nah, this person's still alive." And and in both these cases, there were people like from the transplant group or something who were like, "Oh no, that's okay, it's fine." And they're like, "No, nope," and they stopped. And in both those cases, the person survived and lived to tell the tale of how they almost got their organs harvested. And that's what's called a sentinel event. When we talk about medical errors, there are things called sentinel events. And sentinel events are things that never should happen, right? Like the wrong limb being taken off, or someone dying from a complication, or a near miss. So this would be a near miss. I know it's kind of funny. You'd think it'd be called a near hit because they didn't, but a near, comma, miss, right? The Where someone actually had to intervene, where in these cases the surgeon, and arguably, yeah, that was good. It was the final check. The surgeon had to do the surgery, stepped in and said, no, we're not doing the surgery. This is wrong. This person's still with us. Um, those types of sentinel events mean that we need to look at the system a little bit better. It means that if this is what's coming to the news, there might be ones we've even missed that we didn't know about. So it means that the system. Now, does that mean that our transplant system is completely ruined and broken and terrible? No. Does it mean we're killing people left and right? No. It means we need to go look at the system, look at what we're doing, and probably fix the criteria a little bit. They tried to do a good thing by saying that people who were going to die in this way, instead of brain death, waiting for brain death, saying people can, with circulatory death, that is, their heart has stopped, and they didn't want CPOs, so their heart has stopped, that those people could now donate, and they created a pathway for that to happen, that death, that increased it. But you probably need some stricter criteria or some double checks or some ways to make sure that this person isn't coming. And I think a lot of it, as someone who I have taken quite a number of people off of life support at the end of life, as a hospice doctor, I'll get people who have said, I don't want, I don't want to be in life support. And then, the paramedics not having their advance directives, put them on. And the family calls me, and they send them down to me, and I take them off. Wait for everyone to show up. Sometimes we'll leave someone on there until everyone can show up and say a prayer or whatnot. Or sometimes people get put on life support, and the family's like, okay, you know what? We're going to wait 6 months. We're going to wait so long. Sometimes it's like 2 years, right? And a lot of times people will live in these institutions called LTACs, which are long term care settings for people on ventilators. And and it's kind of sad because people on these LTACs as they're there, by the time they come to me, now mind you, selection bias, I don't see the people who get better, right? So, I mean, there's a reason LTACs exist. There are some people who get better and they never become my patient in hospice. I only see the ones who fail. So take what I'm saying with a little grain of salt, right? But when I see these patients who have failed, who don't, and their families like, wow, they're just suffering at this point. Because sometimes by the time I see them, the body's not made to be laying, in a bed 24/7, 7 days a week on a ventilator. And so people will get bed sores, their kidneys will fail. They can have, they'll have feeding tubes and again, bed sores and they don't wake up and they get pneumonia after pneumonia after pneumonia and until they get a drug resistant one. And sometimes that's what leads them to calling me. But sometimes people come in and I have to take them off their ventilators. Or they've been in the ICU and the family says, no, we don't want to go down that pathway. Just, you know, you know, they've had lung cancer. Now they had a pneumonia and they're in the MICU. They put a vent. They wanted to see if they'd get better, but they're not. So let's just take it off. So there's a lot of reasons I will have seen this. Here's the thing, on television, we imagine people die like right away. The joke, right? Pull the plug, right? Just pull the plug. And then of course, that's how it is in the TV. They take it off and then you just flatline. That's not how it is in real life, unless someone's next breath depends on the machine. High level spinal cord injuries, severe brain damage. The A lot of times people can live a day. I've seen different patterns. I've seen people die within 5 minutes. Again, usually that's someone whose next breath depends on the machine. So, you know, then I have seen people, the most common thing is several hours, like between 2 to 6 hours, because the lungs or the heart compensates. So the heart starts pumping and says, oh, this ain't good. We're going to breathe fast. Then the lungs, if you're able to breathe on your own, again, if your next breath doesn't depend on the machine and you can breathe on your own, but you're not breathing efficiently because you have really damaged lungs, for example, if that inefficient breathing, you might breathe super fast and super shallow. And that can keep you alive for several hours sometimes. And then then I see a third group, people with COPD, advanced COPD, like the person who smoked for years and years and years and has been on oxygen. They stopped smoking, but they still were on oxygen. And now they got a bad pneumonia and they go to the hospital. That's actually an interesting case because it's not lack of oxygen. It's actually too much CO2. Because remember, when we breathe in, we're breathing in oxygen, and then we breathe out CO2. Right? That's breathing. So most of the time we think of people dying of respiratory failure, we're thinking that they can't get enough oxygen. People with bad COPD, I can put them up to an oxygen mask and they'll get enough oxygen, but then they can't breathe out. They can't, their lungs are so damaged, they can't create the force to breathe out CO2 effectively. And so the CO2 starts to build up in their body and they actually die of CO2 poisoning. And so that usually takes about 2 to 3 days. So that's the third category I'll see. And then the fourth category I'll see is people who either live several weeks and maybe die of something else, like the kidneys, because they also stop dialysis, or maybe they stop the feeding tube or something else, right? And or they continue to live. Some people, if they don't have those other issues, may just survive. And so I always, before extubation, prepare people for that because those are very different outcomes. And I think what might be happening a little bit is that the guidelines that they've created, and I haven't read them. I have to go and maybe we follow up next time when I talk. I'll try to find the transplant guidelines. and see what exactly, to kind of clarify. But like I said, I don't think this is oh my gosh, this is a whole epidemic of living people being, I think Michael Crichton did a horror story about that called Coma or something like that back in the 70s. This was right out of one of his early stories. Was it Coma? I'm trying to remember. I think so. I think it was called Coma, where they were taking people and who were still alive and harvesting their organs, right? And that's again, that's the thing of horror stories, or when someone has their clone and their there's all those things. That's not what we're dealing with. This is a case where they're already doing it even before Kennedy had suggested that they do it. They're already starting to go back and say, okay, we need to fix this, particularly after that Kentucky case happened. They've been doing it. So, don't throw away your donor card. It's okay. But just be aware that that's kind of what's going on. Um yeah. So, I don't know what else we have going on today. The hmm, hmm. So, yeah, other things of interest. You know, it is I will tell you one of the things I'm doing. If you happen to be a physician and catching this, I am doing courses now for physicians. I will be starting in September. So I'll be talking to so if you happen to be a physician, right now, what I'm doing is I'm gathering data uh, from other physicians about what they really want to know. Um, what do they want to learn? My idea is not to necessarily train everyone to know everything about cannabis and medical cannabis, but so you can just be a cannabis doctor. No, I want just the everyday doctor to know what they need to know because of everything we just talked about, how there are transplants and medication interactions. I mentioned warfarin, for example, a blood thinner, right? So there are all these different things. Who is who has addiction versus who is taking it every day because they need it medically versus who's taking it every day because they need it for symptoms that need further treatment. Sometimes people self medicate because we don't, they don't tell the doctor. And so they're self medicating. And so as they self medicate, maybe they're not taking the right doses of the right thing. And I as a doctor look at that and go, "Well, why are you taking that?" And then they can say, "Well, I'm taking it for my anxiety." And I'll say, "Have you tried an SSRI?" And they'll be like, "No." I mean, yes, or behavioral therapy, cognitive behavioral therapy. Particularly with things like PTSD. I often say that's a good example, and you've probably heard me say this before, that people with PTSD really do benefit from cannabis. But on the other end, there are people who use cannabis, with PTSD, not to help them get better or live their life, but to just completely hide, you know, to live in the haze, so to speak, right? Where it's like, I don't have to worry about life if I'm just high all the time. That's different than the person who's like, I use cannabis so I can get a good night's sleep without nightmares. And that lets me go to work during the day. Right? Or I use it to prevent the intrusive thoughts that might cause me to lead to self harm or harmful, decisions. Right? Those are two different types of people. And This other person who's using it to kind of get past the haze, they might need addiction help because they might be in a level of addiction, but they also might need cognitive behavioral therapy. So might the other one. It'd be like, great, you're using cannabis, but are you still getting flashbacks? Are you still getting stuff? EMDR or cognitive behavioral therapy might help you get through the day. So as a doctor, I personally think we can't just nod and say, yeah, yeah, you're using cannabis. It's good for you, or go, no, 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 you should not be using it. We need to have a balanced day and say, why are you using it? What can we do to help? What can we do to make things better? What can we make, And so that is why we use cannabis. That's why we tell people about cannabis. And that's why a doctor needs to know, your everyday PCP needs to know, or maybe your oncologist. That's a different lecture, right? What in cancer can cannabis help? You know, there are people who think cannabis can help everything, including the cancer. And I would not stop chemo for cannabis. And there are actually some chemos that we have questions. It's not really chemo, some of the immuno drugs, whether or not cannabis can help or hurt. And then, but then there's things like nausea. So if you can tolerate the side effects of the chemo enough that you can take it, that's going to help you live longer, right? So if you're using cannabis and now you can tolerate the nausea, whereas before you couldn't, well, now the doctor doesn't have to stop the chemo because they had to hospitalize you for dehydration. You could, because you can eat and drink and stuff. So there's a lot of things, from a cancer doctor view that you would look at. And so all of the doctors, I think need to understand, even if you're not prescribing, even if you're not even dealing with it, even if you're like, oh, I don't deal with cannabis at all. No, it's not my thing. Your patients are still using it. So I am creating a program to teach everyday doctors what they need to know about cannabis. So if you're an everyday doctor and you want to know more, reach out to me. Right now, I am developing my curriculum. And so I'm asking doctors what they want to know and how they want to learn it. So feel free to reach out for that. Definitely looking forward to talking to more people and doing that. The Yeah, and like I said, if anyone's here, if anyone has questions, we are in about the last 7 minutes of here, and I might wind up a little bit early if we don't get too much. But I want to give a chance again for anyone with questions to pop in with any of the questions they might have or any thoughts. Um, but yeah, the other things, the yeah. So we've talked a lot about the heart today. You know, Another thing that's good for the heart, socialization. It's odd, but in longevity studies, people who live in larger family groups, who socialize, who hang with each other more, live longer. The There's something protective. I talked about the Mediterranean diet earlier. And so this is the different aspect of the heart, right? Not necessarily the heart, but the heart. And the fact that family ties, socialization, being around people you love, being around, uh, having a social ties, gatherings, having dinners with people, that actually is protective. In fact, when you read the full guidelines for the Mediterranean diet, that's one of the things they say to do is eat with other people, spend time with other people, socialize. That is actually protective of your heart. And so, yeah, that is one thing I would say is Protect your heart. Go out, spend some time with people you love this weekend. You know, and people are like, "Oh, I don't know if I wanna go out and especially in post-COVID, we're all still just a little agoraphobic. We're all just like, "I don't wanna go out. I don't wanna just wanna stay on my couch and watch videos and, catch up on the latest streaming thing. I don't know if I wanna socialize." But it turns out that's good for your heart too. So, if you wanna protect your heart, don't smoke, take omega-3s, socialize, eat more fish, eat flaxseed, hemp seed, stuff like that. Low saturated fats, so those unhealthy, no trans fats, whole grains, vegetables, olive oil, you know, olive oil, avocado oil to kind of balance that ECS. I have, they've done some cross cultural studies and have shown that the Mediterranean diet, the Scandinavian diet, and the Japanese diet are all associated with longevity. I personally think that the traditional Mexican diet will actually pan out to be very healthy too. I just don't think it's been looked at because whenever we think Mexican food, we think Taco Bell or Tex Mex. But Mexican food, I think, sure, tortillas, nachos. Mm. But if you're doing traditional Mexican food that's very heavy in beans, where again you have that really good fiber, some avocado, which has that omega-9, much like the olive oil, the avocado oils, the whole fruits and veggies, you know, a little bit of meat, but again, very heavy in like good things like vegetables and beans and healthy oils. I think at the end of the day, um, and if you've ever had, I've had a lot of patients over the years in Latino communities. Every every family has a 90-year-old abuela who grew up in Mexico, exercised a lot, did a lot of rural, hard work in in rural Mexico and ate very healthy foods. And even today, now that they're in the States, still goes to the local small Mexican grocery store and buys fresh produce for their vegetable soup, their caldo, right? And so I think there's something to be said about that. There's a lot of different cultures. We just talk about those three that they've done studies, but there's a lot of cultures. If you actually really looked deep into their diets, would probably show that they are healthier, or there's ways to make them healthier to adapt it. You don't have to just eat Italian food. In fact, Italian food, again, kind of like Tex-Mex, isn't the healthiest thing, but Mediterranean, right? Um, you don't just have to eat Mediterranean food. You can expand your diet to other cultures, other things, just kind of follow these basic principles. It is now 7:59. I think I'm going to wrap up just a little early. Um, I hope everyone's had a great day. Enjoy your weekend, and I'll talk to everyone next week. Thank you.